Let's go over the warm-up review. First question. A patient with an IL-12 receptor deficiency is at particular risk for which type of infection? Mycobacterial infections. Next, what drugs are used in the treatment of chronic gout? So allopurinol is the drug used most often. Probenecid is used occasionally. You can also use colchicine or NSAIDs long-term if you need to. Last one. What are the classic symptoms of Sjogren's syndrome? So with Sjogren's syndrome, you're going to have xerophthalmia, which is dry eyes, xerostomia, which is dry mouth, and arthritis. Now let's move on to the lecture.
Hello everyone and welcome to our step 1 video on alcohol abuse. You know what, by now you might be getting a little tired of studying. Here we are with our stupid DIT faces just staring at you through the computer. Blah, 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 learn this, blah, 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 memorize that. Saying things like 4 stars and high yield. How many times can we say high yield in this course? Does that even mean anything anymore? What does anything mean anymore? Why are we all here? Man, I need another drink. I mean, a drink. I don't drink before every lecture. I just like holding it and smelling it. I know it's only 8 a.m. in the morning. You don't have to tell me every day. Not my mom. All right, so let's get started. First, we need to define substance use disorder. So the DSM-5 combines what used to be known as substance abuse and substance dependence into what is now known as substance use disorder. So substance use disorder is a problematic pattern of substance use that leads to significant impairment or distress. Now you need 2 of the following things over 1 year. Now one way to remember this is that 21 is the drinking age and you need 2 of the following over 1 year. First one is tolerance. So you need more and more to achieve the same effect. Next is withdrawal symptoms. So many times the withdrawal symptoms will be the opposite of the intoxication symptoms. Next we have persistent desire or unsuccessful attempts to cut down. You might actually recognize that as part of the CAGE questionnaire for screening for alcoholism. Have you ever felt the need to cut down? And we'll talk about CAGE in a little bit. Next we have significant time spent obtaining, using, or recovering from the substance. Next, we have important social, occupational, or recreational activities reduced because of substance abuse. Next, we have continued use in spite of knowing the problems that it causes. So you have problems at work, at school, at home, you don't really care. Next, we have just craving. And then next, we have recurrent use in physically dangerous situations, like when you're driving. Next, we have failure to fulfill major obligations at work, school, or home due to use. Then we also have social or interpersonal conflicts related to substance use. And then individual takes substance in larger amounts or over a longer period of time than was originally intended. So those are your criteria. Next, let's go through the stages of behavioral change. So if you are addicted to a substance, there are stages that you go through in order to get off of that substance. So these are called the stages of behavioral change. So the first one is called pre-contemplation. So this is you're really not yet acknowledging that there is a problem. And then the next one is contemplation. So you know you have a problem, but you don't want to change yet. Next, we have a preparation, or also referred to as determination. This is you are ready to change. And then you have action or willpower, and that's changing that behavior. And then you have maintenance, which is just maintaining the behavioral change, like not using. And then unfortunately, the last one is relapse, or returning to old behaviors and abandoning new changes. All right, so now let's move on to alcohol. So many of you have experienced the effects of alcohol, but let's put this into words. Alcohol is a CNS depressant. Patients who are intoxicated on alcohol will have mood elevation, a disinhibition, a decrease in anxiety and sedation. And then with more severe intoxication, patients can have a severe mental impairment, somnolence, and even respiratory depression, which can be life-threatening. Now, withdrawal symptoms are generally the opposite of your intoxication symptoms. So if alcohol causes sedation, then your withdrawal symptoms are going to be things like agitation, anxiety, insomnia, and even tremor. Have you ever woken up at 3 a.m. after drinking too much and not being able to get back to sleep? Yeah, me neither. Now, where does alcohol act on the brain? Well, alcohol has several actions, but most notably, its effect is going to be on GABA receptors. So this is very similar to the mechanism of action of the benzodiazepines and the barbiturates. So how do we treat alcohol intoxication? Well, the treatment for alcohol intoxication is really just time. So a patient comes in intoxicated with alcohol, really you're just going to put them on a bed, maybe give them some fluids, and wait for it to clear out of their system on their own. That's all you can really do. Now, there's no reversing agent for alcohol. Now, you still have to think about the ABCs. Make sure that they have an airway, that their ability to breathe on their own is still intact, and also that they don't aspirate and vomit, because that's a very common scenario as well. Again, no reversing agent in alcohol. Let's talk about delirium tremens. So there are some things we need to do for withdrawal, though, if it's severe. First and foremost, you need to realize that alcohol withdrawal can be life-threatening. We've already mentioned that the withdrawal symptoms include things like anxiety, tremor, agitation, and maybe some tachycardia. Severe withdrawal can cause delirium tremens. Patients will have acute cognitive changes, confusion, nightmares, agitation, disorientation, even visual and auditory hallucinations, fever, hypertension, and diaphoresis. Now, the symptoms begin, this is important, about 2 to 3 days after cessation of alcohol. Patients will often think something is crawling on them, something like ants or even rats. Now, if the withdrawal is severe, then patients can have seizures, they can have extreme autonomic hyperactivity like tachycardia, they can have tachypnea, hypertension, and some of this can even lead to some life-threatening situations. Look out for a question on your test where a patient comes into the hospital for maybe an elective scheduled surgery and then has a seizure a few days post-op. It's really just because they haven't had anything to drink while that person's been hospitalized. Now, what is the treatment for alcohol withdrawal? Benzodiazepines or alcohol itself. So alcohol is actually a potential treatment for alcohol withdrawal, though hospitals don't prescribe alcohol to patients much anymore. I always wanted to write that beer to bedside on my admission orders, but I never got to in residency. Now, most of the time, we're just going to use our benzodiazepines to help prevent alcohol withdrawal. Now let's talk about alcoholism. So let's talk about some of the complications associated with long-term alcohol use. Alcohol in excess can damage the liver. You can have fatty changes of your hepatocytes. It's going to elevate your GGT, which is actually one of the sensitive lab markers for alcoholic liver damage. Also, the aminotransferases. Remember, our AST and our ALT are both going to be elevated, but that AST is often twice as high as the ALT. And so a way you can remember that again is AST can stand for a Scotch and tonic. Now, this damage may lead to alcoholic cirrhosis. Now, will the majority of alcoholics develop cirrhosis? Well, no. Actually, about 10, maybe 20% in some studies will show that patients develop alcohol cirrhosis with that prolonged excessive use. Now, other adverse effects of long-term alcohol include things like hepatitis, pancreatitis, peripheral neuropathy, and even testicular atrophy. Now, another interesting potential test question is on Saturday night palsy. So this is where you compress the radial nerve in the spiral groove. Now, this happens if you kind of pass out and you have your arm kind of draped over a chair or something really hard, and it really compresses that nerve. Now, alcoholics are at a high risk for aspiration pneumonia as well. So if an alcoholic has impaired mental status due to that alcohol, then vomits, and there's always that chance for aspiration. You always want to think about anaerobic bugs causing that aspiration pneumonia. However, you also want to think about Klebsiella in alcoholics as well. Klebsiella loves to infect people with weakened immune systems, and alcoholics definitely fall into that category. Next, let's talk about screening for alcoholism. So what's that questionnaire that we always use? It's the CAGE questionnaire, C-A-G-E. C is for cut back. Have you ever felt the need to cut back on your alcohol use? A is for annoyance or annoyed. Do you get annoyed when people ask you about alcohol use? G is for guilt. Do you ever feel guilty about your use? And E is for eye opener. That's the bad one. Do you ever have to have the need to drink just after waking up? So definitely know your CAGE questionnaire. All right, so now let's move on to what we call the patient profile. So we're going to go through a sample question. We're going to tease out all the high yield points. And the title of this patient profile is the confabulating drunk. So here's our question. A 52-year-old man presents to the emergency department disheveled and confused. He has difficulty answering questions and believes that he's been in Russia for the past several days. He is ataxic and on exam has horizontal nystagmus, ophthalmoplegia, and sluggish pupillary reflexes. His blood pressure is 95/48. His heart rate is 110. Laboratory examination reveals glucose of 65, creatinine of 1.2, aspartate transaminase 420, alanine transaminase is 150. His drug screen was positive for opiates, alcohol, and benzodiazepines. The patient is given intravenous fluids with glucose, which promptly results in the patient becoming comatose. Which treatment would most likely lead to improvement of his symptoms? All right, so since we're in an alcohol video, this patient likely has a problem with alcohol, right? So his appearance is disheveled and confused. That could be from alcohol alone. He's testing positive for benzodiazepines and opioids. Maybe there are contributing factors to the symptoms as well. Now, his other labs reveal hypoglycemia because he's probably not eating very well. His AST is 2 times that of his ALT. So again, this looks like alcohol intoxication. But what else is cluing us into an important diagnosis here? Well, he has memory problems. He has ataxia, eye abnormalities that may seem slightly odd, but the giveaway here is that he got worse when he got fluids and glucose. Good old-fashioned alcohol intoxication really shouldn't get profoundly worse with just fluids and glucose. So the diagnosis here is Wernicke-Korsakoff syndrome. So let's take a minute and go through this in detail. So Wernicke-Korsakoff syndrome is another problem we tend to see in our alcoholics, anyone who is malnourished. So Wernicke-Korsakoff is caused by thiamine deficiency, which is vitamin B1. So it's actually 2 sets of symptoms. Now, Wernicke encephalopathy is the acute life-threatening neurological pathology associated with that thiamine deficiency, and then the Korsakoff syndrome is the long-term consequences of Wernicke encephalopathy. So let's see if these symptoms match what our confabulating drunk has. First, we have the Wernicke encephalopathy. What's that going to include? Well, confusion, nystagmus, ophthalmoplegia, ataxia, sluggish pupillary reflexes, and then coma and death if untreated. So the big 3 probably to remember here is going to be that encephalopathy, the eye symptoms, and the ataxia. Now let's talk about the Korsakoff syndrome symptoms. So that's going to include anterograde amnesia, so the inability to form new memories, retrograde amnesia, loss of existing memories, and then confabulation, that's that false perceptions or memories, and then we're going to have the hallucinations as well. So Wernicke-Korsakoff does have the tendency to affect specific regions of the brain. You'll sometimes see specific damage to the medial thalamus and the mammillary bodies of the posterior hypothalamus. So for treatment, we want to give this patient intravenous thiamine. It will actually help resolve the acute symptoms of the Wernicke encephalopathy. So what's the deal with the encephalopathy getting worse with glucose administration? Well, alcohol can impair the liver's ability to undergo gluconeogenesis. Also, alcoholics don't have the best diet. Therefore, they often come in with that hypoglycemia. So that question again is, should you start by giving your slightly obtunded alcoholic hypoglycemic patient a bunch of glucose? Maybe that's going to perk them up. Well, the answer is, of course, a big no, as we saw with our confabulating drunk. The active form of thiamine is a major cofactor in the metabolism of glucose. Therefore, anything that encourages glucose metabolism will actually exacerbate an existing or maybe even a subclinical thiamine deficiency. So if you give your slightly obtunded hypoglycemic alcoholic some glucose, you could turn him into a comatose euglycemic alcoholic. So this is why you always give thiamine before glucose to any patient with mental status changes or any malnourished patient or any alcoholic patient. Now maybe you've heard of something called a banana bag. These are pretty commonly used in the hospital. These are just IV fluids that have kind of yellow urine looking appearance to them. And those are IV fluids with a lot of vitamins in them. So they include a lot of thiamine, folate, magnesium, multivitamins in general. So commonly alcoholics are deficient in those things because they're drinking alcohol and they're not eating things like fruits and vegetables like they should. Okay, so in summary, Wernicke-Korsakoff, often seen in alcoholics. Patients will be confused, ataxic, have nystagmus, ophthalmoplegia. They'll have memory problems. They'll also make a bunch of stuff up. So this is due to that severe thiamine or B1 deficiency. Glucose will make them worse. Therefore, always give thiamine before glucose. All right, so now let's move on to some other stuff. Now we're going to talk about Mallory-Weiss syndrome. So Mallory-Weiss syndrome is a longitudinal laceration of the gastroesophageal junction caused by excessive vomiting. So too much alcohol makes you want to vomit. Now often patients will present with hematemesis. So this is painful and quite scary to witness as a patient. What are esophageal varices? How are they different? Well, these are actually extremely dilated submucosal veins in the lower third of the esophagus. So these are caused by portal hypertension, usually due to cirrhosis. So these things can kind of go together. Esophageal varices tend to bleed quite a bit more and will actually present with coffee ground emesis as well. Mallory-Weiss tears generally aren't very life-threatening. They're going to stop bleeding, but a bleeding esophageal varix is quite life-threatening, can be a big deal. Let's talk about the long-term treatment of alcoholism. So what medications are effective in helping to prevent relapse in our recovering alcoholics? So you have a series of bullet points here. One of the oldest, still one of the most effective therapies used to prevent relapse is group therapy, something like Alcoholics Anonymous. Patients can go to weekly or even daily meetings. They can receive counseling, also get a sponsor who can help them as well. Cognitive behavioral therapy is also effective with this as well. Let's talk about some medicines though. Naltrexone. Well, this one doesn't sound right. Isn't naltrexone an opioid antagonist? Well, it works for alcohol because endogenous opioids are involved in the positive feelings that come about with alcohol use. So you don't feel as good as when you drink, and that's why this medicine is effective. Disulfiram. So the disulfiram you can actually take either regularly or just occasionally when you're going out to party or whatever. So you're not tempted to drink, because if you start drinking while on disulfiram, you're going to feel terrible. You're going to start throwing up, getting flushed, and have that disulfiram-like reaction. Now, we've gone over that mechanism several times in this course. Recall that disulfiram is going to inhibit acetaldehyde dehydrogenase, which will lead to an accumulation of acetaldehyde if you drink alcohol, and that's what makes you feel bad. Another medicine is topiramate. That's had some success as well. It's going to affect glutamate receptors. And then the fourth one is called a camprosate. A camprosate works by modulation of the glutamate neurotransmission as well. So all of these have actually been studied, somewhat effective in helping the relapse of alcoholism. All right, so that's it for the lecture part. It's time for that end of session quiz. Try to answer those on your own, and then we'll go through them together. First question, what are the stages of behavioral change? Remember, we have pre-contemplation, where you're really not thinking you have anything wrong with you. You got contemplation, where you say, I have a problem. You have preparation, where there's actually an intention to change. There's the action part, where you're actually doing the work, you're making that behavior different. And then there's maintenance, so you're consistently change, you're staying away from alcohol or drugs or whatever. And then unfortunately, there's also the relapse, where you're going back to your old behavior. Next, what is the mechanism of action of the drug disulfiram? Why would this drug make you feel terrible when taken with alcohol? So remember, disulfiram is going to inhibit that acetaldehyde dehydrogenase. So if you drink alcohol, you accumulate acetaldehyde, which then makes you pretty sick. Next, when does delirium tremens occur? So remember, it's about 2 to 3 days, maybe a little bit longer in some cases, after cessation of alcohol. All right, so we have a couple of rapid fire facts here. Medical treatment for alcohol withdrawal, benzodiazepines is the answer there. And then next we have atrophy of the mammillary bodies, so that's going to be seen in Wernicke's encephalopathy and Korsakoff syndrome. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
How are you feeling, 00? Sweating? Nausea? Confusion? Palpitation?
What have you done to me?
I haven't done a thing. It's your own ways that'll be your undoing.
I simply kept you locked up here long enough to let your body fully metabolize your precious vodka.
No martinis means
No 00.
You are sick, Gold. You have reached a new low. What's happening to me? I'm having withdrawal seizures.
Don't make me laugh. Alcohol withdrawal causes generalized tonic-clonic seizures. You're just a little tremulous.
If I could just reach my pen.
No, there's no escaping this time, 00. No!
Don't you know the treatment of choice for alcohol withdrawal is benzodiazepines? I never go on a mission without a dose of chlordiazepoxide.
No!
That's right, Gold. Run scared. No one comes between me and my martini.